tool for monitoring pressure ulcer healing, a practical guide. Thank you for WoundRounds today for sponsoring this webinar. My name is Deborah Kurtz and I'm your moderator today. What we wanted to do is share with you a few bookkeeping items about the webinar. For starters, those of you who pre-registered should have already received by email a copy of today's handouts so that you can follow along as we're going through the webinar today. But rest assured, if you did not get a copy of the handouts, we will also be pushing out handouts following the webinar via email, so you get another chance to get a copy of handouts. Another bookkeeping item is today's webinar will be recorded, and we share the link to this archived webinar on the WoundRounds website. So if you have a friend or colleague who wasn't able to attend today, they will get an opportunity to access this content. And then wanted to let you know that all the participants today are muted, so that means that you cannot ask questions verbally. But if you notice on the upper right-hand side of your dashboard for the GoToWebinar, you're able to type in questions, and we'll be taking then questions at the end of the webinar. Our speaker, Kathy O'Toole, will be answering those then. And if you decide to not ask a question today but would like to follow up directly with Kathy O'Toole following the webinar, we'll be providing her contact information as well. So there's lots of opportunities for you to engage and interact with today's speaker. So with that being said, I'd like to formally kick off our webinar today and tell you a little bit about our speaker. Our speaker is Kathy O'Toole, who comes to us after a really accomplished career in both wound care, both on the clinical side in facilities, but also in the industry side of consulting. And so Kathy O'Toole, in addition to working for WoundRounds, the sponsor of today's webinar, she is also a small business owner and the proprietor of Specialties in Wound Care, a company which provides wound care education, training, and consultation to companies across the United States. So I feel very fortunate to have Kathy with us today. A little bit about myself. I'm your moderator today, and I work in the space of healthcare industry, but also specifically in the area of long-term care and wound care. So it's my pleasure to be here today and to help moderate this event, and our thanks to WoundRounds for making this possible. We already had a chance to show a poll about yourselves, and so next what I'd like to do is officially turn this over to our speaker and presenter today, Kathy O'Toole. Thank you, Kathy, so much for joining us today. Please take it away.
Thank you, Deb, and good afternoon, everybody. Thank you for the opportunity to speak with you today. The objectives for our presentation are that we will describe the purpose of using the push tool for measuring a wound's progress towards healing, discuss the 3 essential elements of the push tool, and discuss the wound assessment parameters that comprise the push tool. We will also have an opportunity at the end to review case studies demonstrating the effective use of the tool. So the push tool, we'll go back in time a little bit. The problem the push tool addresses is really specifically, or was specifically, pressure ulcers. As we know, pressure ulcers are very costly. They're often devastating. They affect both morbidity and mortality. They require treatment. They cause increases in the length of hospital stays. There are some estimates that the additional length of stay is up to 14 days. The cost can be up to $40,000. There was a case reported, an article in 2008 that reported there were 2.5 million patients treated in acute care hospitals with an annual cost of $11 billion, and that was specifically for pressure ulcers. We also know that these patients are discharged into long-term care facilities, home care, SNFs, LTACs, where they continue to need treatment and additional expenses. Related to prevalence and documentation, this is kind of where the need for the push tool really began. In the early 80s and through the 90s, the prevalence of pressure ulcers was alarmingly high. Documentation was an issue because many clinicians were utilizing reverse staging as a method to indicate wound healing was occurring. And so what had happened, So with the pressure ulcer prevalence so high, leadership at a professional medical manufacturing engineering company in the healthcare space developed a group of professionals, and their focus was to look at pressure ulcers, how to heal them, how to reduce the prevalence, and basically put them on the roadmap. So in 1987, that group became known as the National Pressure Ulcer Advisory Panel. Formally, as a group in 1987. Their function was to address the issues related to pressure ulcers, and they are now a freestanding international organization as they work with the European Pressure Ulcer Advisory Panel. I wanted to go a little bit further into what they have done for all of us. They have quite a number of accomplishments, and to give you an idea of the work they've done. And just here are some of the issues they've tackled. In 1999, at their national conference, they redefined staging of stage 1 pressure ulcers to include a definition that discussed darkly pigmented patients. In 2000, they discussed avoidable versus unavoidable. In 2001, they looked at the data from 1990 to 2000 and provided a monograph with all that P&I data. In 2003, they came out with information about the state of pressure ulcers in America. 2005, deep tissue injuries. And basically what they're doing now is that they work very collaboratively with the National Institute of Health on public policy issues. The members of the NPUAP are well publicized. They write manuscripts, monographs, assessment tools, and things of that nature. So the group is a very highly functioning group. So back to the 1990s, they really saw that there was a need to address pressure ulcers in a very specific way and to be able to show whether they were healing or not. So in 1997, the NPUAP developed and then introduced their PUSH tool, which is the Pressure Ulcer Scale for Healing, or PUSH tool. It monitors pressure ulcer healing over time, which is a really important point about the tool, meaning that it needs to be used repeatedly in order to gather data, to look at it over time and to see, is the pressure ulcer moving towards healing or not. The tool was validated in clinical use, and just to keep in mind, the tool is not a comprehensive assessment. It really picks out pieces of a comprehensive assessment to look at it to determine, is the pressure ulcer moving towards healing or not. And that tool is available on the NPUAP website. A little bit more about the tool. In developing the tool, it was really important that they had a tool that was going to be simple to use, so that it would be quick and easy to use in the clinical setting. And again, it does not replace a full assessment, and it can be used in any clinical setting. The tool needed to be validated, meaning that the tool measures what it says it measures. Another way of saying this is that the element in the tool observed and scored within the tool are indicative of wound healing, and that's very critical to understanding the tool. Sensitivity is an issue. It's very important that the tool is sensitive enough that when measuring those parameters, it does indicate a change or wound progression. The three components of the tool are the scoring tool, the healing record, and the healing graft. This slide here shows actually the tool. So you'll see in the tool actually was designed to monitor three critical parameters, and these are the parameters that are most indicative of healing. They are the wound surface area, wound exudate amount, and the tissue type. We know that for treatment purposes, it's important to assess additional parameters such as undermining, tunneling, the color of the exudate. But I want you to notice that each component here, length, width, exudate amount, tissue type, they receive a subscore, and the total score can be 17. So we're going to go a little bit further into that in just a moment. This slide here, this shows you the pressure ulcer healing record. It's the second component of the pressure ulcer healing, the PUSH tool, I'm sorry. And this is where the results of the assessment and subscores are recorded. It records the date of the assessment, the subscore for each of the three parameters, and the exudate amount and tissue type, and you get the total score. This will be important. We'll see later on when I begin to give you examples of the use of the tool, where you'll see that as you record on this record the date of the assessments and look at the length and width, the exudate amount, and the tissue type, you'll see that the numbers within those subscores may change as well as the total score. And so we may have one where the tissue type goes from necrotic tissue to granulation tissue, even though the total score may be the same. And you'll see that a little bit later on. The third piece of our PUSH score is the pressure ulcer healing graph. This is where the total scores for each of the assessments are recorded. As the wound heals, hopefully you will see that the number decreases, Thus, the graph will provide a graphic view of the healing over time. It's also a way to really look at and think about, is the treatment that I'm providing for this wound effective, or is it time to perhaps make a change in something? So we're going to go a little bit deeper into the tool. So you'll note here, measuring the wound, I've highlighted the length times the width. What the length times the width gives us is the wound surface area. It's measured in centimeters, and basically what you want to do is measure it according to what's referred to as the clock method, so that the length is always 12 to 6, or from head to toe. Measuring the width is from side to side, or perpendicular to the length, and that will be from 3 to 9. This will give you the surface area. And you may ask, why is the depth not included in this? Keep in mind that including the depth will give you the wound volume, which again is not necessary for our push tool, but it is, however, important and a critical part of your comprehensive assessment. And just remember that we're taking pieces of our comprehensive assessment in order to measure if wound healing is occurring. In addition, wounds heal by contraction, and so what we're looking for and what we observe by seeing the length times the width decrease in size is that what that's telling us is that we do have wound contraction, and so we know that healing is occurring. The next slide, this slide shows you measuring the wound in the clock method. The head to toe will be the 12 to 6 measuring, side to side will be 3 to 9. It should always be done in the same way, and again it should be documented in centimeters. This is also very helpful in your charting and documenting when you are trying to describe where tunneling or undermining occurs. Again, you can use the clock method to say, there's a tunnel at 5 o'clock that moves from 5 to 6, it's 3 centimeters. So the clock method is a very valuable tool to use, whether you're using it just for the length and the width or for the depth. It's also good for tunneling and undermining. And just to reiterate that the push tool is measuring the wound surface area. So this is a nice picture of the clock method. You'll note again the person's in the right side lying position. So you would not really want to call the 9 o'clock position the 12. Keep in mind the 12 is always towards the head. So you can see here the 12 to 6 would be our length, the 9 to 3 would be our width, and you can also see here in this picture that at 9 o'clock we've got an undermined area. So the clock method is very valuable when trying to document about other deficits within the wound. And again, just to reiterate, a comprehensive wound assessment, the clock method, helps you to identify deficits within the wound bed. So again, here's our push tool. If we had measured that wound, let's assume that it measured 2 by 2. So what we would do is multiply 2 times 2, which gives us a value of 4. When looking at the push tool, we look for 4.0 centimeters within that scale, and we see that it would get a score of 6. And so on our push tool, we would simply give it a score of 6. Very simple. Moving on, the second element in the assessment is the exudate amount. Again, the values are none, light, moderate, and heavy. It's important to note that although the amount of exudate is important, it's important to note the amount of exudate a wound is producing after the dressing is removed, but before a topical agent is applied. The exudate from an acute wound is a normal part of the healing process. It helps maintain a moist wound bed, which is essential for cell migration. Exudate from acute wounds contains water and nutrients, electrolytes, inflammatory mediators. Remember, we're healing, going through an inflammatory phase into proliferation. Exudate in chronic wounds is thought to be more corrosive, so it's very important that we notice how much we have there. So a low score on this parameter is not necessarily a good thing. If you look at this scale, it goes from right to left or high to low. So in exudate amount, the number 3 would be heavy exudate. That's not necessarily what we want. If you have a dry wound bed, there's no moisture for the cells to migrate, so that really isn't a good thing either. And we'll see a little bit later on when we've got all of our skills, all of our scores filled in, you'll see the value of these numbers. To give you some pictures, might be a little bit easier to relate to. The picture on the left, obviously a very, very dry wound. So there is no drainage here. We also know that a dry, hard, the dry, hard dead tissue represents a burden to the body. Debridement is a normal process in the wound healing process, and so the body would have an extra burden of trying to debride this dry, hard tissue. And so it can be very overwhelming. And instead of moving on to proliferation, we would be stuck in the inflammatory phase, which is what we don't want. The picture on the right indicates a wound that has a light amount of drainage. We probably would want a little bit more drainage there, a little bit more moisture. And again, we would say in our comprehensive assessment that this wound also has some slough in it. It appears that, right between 5 and 6 there may be a little bit of a tunnel. But again, for our purposes in the push tool, we're really looking at just the exudate amount right here. Other examples of exudate, moderate amount, we see on the picture on the left. Again, if we were to do a comprehensive assessment of this picture, we might say, well, the tissue looks nice and red, but it looks a little flat. I'm not sure that I have true granulation tissue there. But in terms of my exudate, a moderate amount would be considered 5 to 10 cc's every 24 hours. The picture on the right, actually we see a couple things with this wound. We see that there's a hydrocolloid dressing. Hydrocolloid dressings are not absorptive dressings. So the exudate that is produced from the wound is not allowed to evaporate away, and so the wound can further deteriorate because that moisture is sitting on the peri-wound area. So this would be a wound that has a large amount of exudate. So when we look at our wound and we say, let's say we had a wound that had a moderate amount of exudate, on our score, our subscore, we would give that a 2. On our push tool, moving to our tissue types, we see that there's 5 categories: closed, epithelial tissue, granulation tissue, slough, and necrotic tissue. And again, note that the tool is moving from right to left or high to low. Necrotic tissue and slough are both detrimental to wound healing. Granulation tissue is needed for epithelialization to occur, which can then help to close the wound. Okay, moving on. Tissue type, the first one would be closed. A closed wound is one in which the resurfacing has occurred and the wound is completely covered with new skin. As an example, we see the wound on the left actually began as the wound on the right. And so we can see now that it's completely covered with new skin. And so on our push tool, we would mark this as a 0. However, if we thought of this wound on the left as a blister, again, looking at the data that the tool will provide, a blister is a separation between the dermis and the epidermis and is filled with fluid. So what we may see then, as we chart on this on the push tool, is that the length times the width will get smaller even though the tissue type would remain the same. So it's critical to really interpret the data that we collect on the push tool, not just record it, but you want to look at it because it is indicating how is my treatment doing, is this appropriate for this wound, or do I need to change it? So analyzing those subscores are going to be very important. But again, for our purposes on the push tool, we would say that this wound is a closed wound. So on our push score, we would give this a subscore of 0. Moving on to epithelial tissue. Epithelial cells are the cells that are present on the edge of the wound, and they migrate towards the center of the wound, thereby covering the wound with new skin. When a wound is 100% epithelialized, it's considered closed. Again, an example of epithelial tissue. We can see here, although our comprehensive assessment may discuss the appearance of the granulation tissue that's there, the moisture, etc., for our purpose here, looking at the tissue type, we can see that there are epithelial buds between 9 and 12 o'clock. Now, if I was looking at this wound and perhaps assessing my treatment, I would say, well, why am I not getting any epithelial buds down at the bottom? But again, for our push tool, we see we do have epithelial buds which are going to occur over a granulating bed. And so on our push tool, next slide, we would say we do have epithelial tissue present, and so we would give that a subscore of 1. Again, going back to the point that they wanted to have a tool that was easy, simple, quick to use, and we can see how easy and quick this can be. So our next tissue type is granulation tissue, and we're going to take a look at that. Granulation tissue is very important tissue. It is perfused fibrous connective tissue, perfused being a very key word there because the perfusion in this tissue actually provides the nutrients in the blood supply to the cells that are going to migrate over it, and that's really going to be important. When we have a wound bed and we measure the depth, what we want to have happen in these wounds is that these wounds will heal by the filling in the bottom up, sides in. Sides in is contraction, bottom up is granulation tissue. So granulation tissue is an essential component of healing. This is when we know healing is really occurring. So even though granulation tissue is an essential component, we also know that it's going to give rise to our next stage, which is the epithelialization of the wound. And just to keep in mind that with pressure ulcers, we are looking for contraction, but that is not going to necessarily occur unless we've got some granulation tissue. So this is a really nice picture of granulation tissue. It's often referred to as raspberry looking. What's important is to note when you're looking at granulation tissue is that it should look like that raspberry, because the cells that migrate across it kind of leapfrog across that tissue and they kind of need something to hold on to put it in very simplistic terms. But just know granulation tissue, it's the vascular supply of the tissue that will, the cells that will migrate across it. So for a wound that has granulation tissue present, we would score that a 2. A 2. I lost my voice for a minute. Our next tissue, we're going to talk about slough, and I just want to take a minute here to talk about both slough and necrotic tissue. They are both devitalized tissue, and as such, they're a burden for the body. Slough is fibrin, bacteria, there's leukocytes in there, there's cellular debris, it's basically dead tissue, and the body needs to debride that. The natural healing mechanism that the body utilizes is that it provides cells that will debride that tissue, whether it's the hard eschar that we're looking at or slough. So the treatment of devitalized tissue, it's a normal event in healing repair. What we know, though, is that we have wounds that have a lot of, or when we have wounds that have a lot of slough or dead tissue, necrotic tissue, it increases the burden of the body. It can actually overwhelm the process and really interfere with wound healing. And so these two are very critical to observe in a wound, because as a clinician, we may want to take steps to provide a treatment that will enzymatically remove that, surgical debridement. There's a variety of ways of debriding that wound, but we just need to know that both necrotic tissue and slough are detrimental and they need to be removed. So this is a picture, a nice picture of slough here. I would say 95% or 97% of this wound has slough in it. Slough is basically moist dead tissue, yellow, tan, gray, white. It can be very stringy, may be adhering to most of the wound bed. In this case, we can see most of the wound bed is covered with slough. Next slide. So on our push tool, we notice that there's slough tissue, and so we would just give this a 3. And again, in your comprehensive assessment, you may want to write down the percentages of slough that is present, but for our purposes in the push tool, we would give this a 3. The next type of tissue is necrotic tissue. Again, another burden. This is an example of necrotic tissue. You can see this wound is just covered with non-viable and dead tissue. This also provides an environment where bacteria can thrive. Again, think of the person, and we don't want to look at the hole in the person, we want to look at the whole person. And so why is it that this person has such a large wound? Why is it filled with dead tissue? For the body to be able to breathe this wound, it would be a tremendous burden. We would have to look at the person, are they being turned, what's their hydrational status, their nutritional status, etc. And so as clinicians, it would behoove us and the patient to remove this dead tissue so that we can move out of the inflammatory phase and into proliferation. Okay, so our necrotic tissue, can we go back one slide in there? I just want to say a couple of other things. So if you can notice I said earlier that slough is moist dead tissue, just to simplify it. You can see here the blackened area. The eschar can be black, soft, hard tissue. It does represent full thickness tissue destruction. It does need to be removed. One thing I would like to add is that if you have a heel that has broken down, that is covered with hard eschar, you need to protect that eschar because healing will occur underneath that eschar. And so oftentimes people will put a skin prep on the edges of the wound, 1 to 3 times a day. If you do have breakdown at the edges and you start to see some oozing or whatnot, just remember that that's also a portal of entry for bacteria, and so we would not want that to occur. Again, back to the push tool, necrotic tissue would receive a score of 4. And so when we look at our push tool with all of our subscores, we see we had a 4 centimeter wound that got a subscore of 6. Our amount was moderate, so we gave it a 2. Our tissue type was slough, and we gave it a 3. And so when we add those all together, simply we come up with 11. That's our total score. So on the pressure ulcer healing record, this is where you're going to record all of the assessments that you did using the push tool, and you'll see what I started was as an example on 4/30 of 12. For the wounds that we just pretended we had, the length and width is 6, the exudate amount is 2, the tissue type is 3. And so you can see that for each date that you've done an assessment, you would record on here what the length and width is, the exudate amount, the tissue type, and the total score. I also want you to notice that the tissue type changes. So we want to see that we went from slough, and now we've got a wound bed that's granulating on 5/14 and 5/21. And so we are moving from tissue type from a sloughy wound to a granulating wound to a wound that's epithelializing to a closed wound. So we're seeing healing in that particular parameter. Now, as an example, if we had an exudate amount that had started off at 0, we would actually want to see that increase. So we want it to go from 1 to, we wouldn't want to see it go up higher because that would indicate that we had a problem there. So again, our record is very important. It's important to look at the record because you're looking for individual trends in the subscores as well as the trend downwards, hopefully, for the total push score. So this last part of the push tool is the pressure ulcer healing graph. And what this records is the total push score. You can see from this that our top number on the push score would be 17. And for our purposes, on 2 of our assessments, our total score was 11. It moved down to 10, to 8, to 7, to 6. And that's really what we want to see on the graph, is that we want to see that it's getting smaller. Our total score is going down, down, down until the wound is completely healed, and then we wouldn't have to. So just to review the push tool requires regular measuring, and that's very important, again, for our record and for the graph purposes. We want to see the subscores and know that we're assessing parameters. It's really key to understand that the parameters that are assessed within the push tool are those that indicate wound healing. When this tool was validated, it did in fact show that the length times the width does indicate that a wound is healing. Reduction or appropriate amount of exudate is showing that's healing occurring as well as the tissue types. And just for a case review, we have a woman, a white female, 65 years old. She's married and lived with her husband up until 3 weeks ago. She's a retired teacher, private tutor. She weighs 145 pounds. And again, we know as clinicians that the height would also be important. Is she 145 pounds at 4'10", or is she 145 pounds at 5'10"? Because that can, be very different and mean something very different in terms of her healing ability. She's a paraplegic secondary to a car accident 20 years ago, so we know this has been long-term. Type 2 diabetic for 12 years, alert and oriented, a good eater, and again we have to look at that. Is she good at eating all of her desserts, or is she eating healthy proteins that will help her to heal any wound that she has? So in terms of her wound history, she developed an ulcer approximately 6 months ago. It may have started from transferring from the wheelchair to the shower. The doctor advised her to stay off of her backside, and so she's been sleeping on an air mattress. The husband's been applying some form of an adhesive dressing, but not sure what that was, and the wound has not been improving, and she just finished a course of oral antibiotics, which tells us something about the wound. So in terms of looking at the surface area, again, this is where we're measuring the length times the width. So we would measure from 12 to 6 and 3 to 9. And again, just to reiterate, for your comprehensive assessment, you would also want to note the peri-wound area. We can see here that it appears to be breaking down. So that leads us to, is there an issue with incontinence, a bowel program? Is the dressing inappropriate? Perhaps there's too much friction and shear. Perhaps the air mattress is just causing some, is it the summertime? Today in Chicago we've got 101 degrees. So all those things become very important. For the push tool, again, just to reiterate that we're measuring for surface area, which is the length times the width, 12 to 6 and 3 to 9. For this wound, let's say that this wound from 12 to 6 measured 4 centimeters and from 3 to 9 measured 3 centimeters. So then we would multiply that. 4 times 3 is 12, and so when we look at our push tool, we see that 12 centimeters falls in the category of subscore 8. So we would then give this wound an 8 for surface area. For the exudate amount, this wound looks very dry. And remember, moisture is key to healing. And so although we really prefer low scores, that's probably more important when we're looking at length times width. But exudate amount, we don't really want the 0. We might want a 1, but really we're looking for something between a 1 and a 2. So this does look rather dry, so let's give this one a 0. So again, on our exudate amount on the push tool, we would give this a subscore of 0. The next thing we're going to look at is our tissue type. The tissue type that we're seeing a lot of tissue that is non-viable. I actually wish that we had a little bit better picture of this. Look at it closer up. You know, as we nurses are, we like to get our noses and things. And so when you look at this wound, you can see a lot of devitalized tissue. So we'll just give this one a 3. We'll say that it's mostly slough, even though it looks like there might be some necrosis in there, but we'll just go with a 3. So what we have now is we have our sub-scores of 8, 0, and 3, which gives us a total push score of 11. So then on our record, so we're looking at this wound. So say on 430, our assessment are the values we just had, an 8, a 0, a 3, and 11. And this is where I want you to notice that the exudate amount went from 0 to 1 to 2, so although that amount increased, we actually want to see that because that's more appropriate for wound healing to occur, even though at the same time our length and width was decreasing. So you can see the assessment on 430 versus the assessment on 5.7, the total push score is still 11, but the tissue itself, the wound itself, looks like it's moving more towards an appropriate healing pathway. And so that's what we want to see. And so as we graph this wound and we graph the total scores, we see that we had 2 11s. And again, if I just looked at that and I want to dig into that, then I'd go back to the healing record to see, well, why did it stay the same if we were assessing that week on week? But we do see in this graph that it went from 11 to 11 down to 10, 7, 5, and again, we're seeing that movement in the direction that we want. So just to kind of reiterate, the push tool is really meant to be only a portion of the data that's collected in a comprehensive assessment. It's made to be simple, easy. You can use it in any setting. It can be used for other wounds other than pressure ulcers. These are some of the references that I used. You can see a number of the articles that were used, very well worth reading. And then some of the resources that we also used were the Agency for Healthcare Research and Quality, very good website there, the American Diabetes Association, American Physical Therapy Association, the Association for the Advancement of Wound Care, AAWC, Dermatology Nurses Association, the National Association for Continence, which was formerly HIP, the National Pressure Ulcer Advisory Panel. I would really suggest that people go on that. There's a plethora of information. It's a wonderful organization. They're very involved in the international community with wound care, and they do quite a bit for all of us as clinicians. And of course, there's also the Wound, Ostomy, and Continence Nurse Societies, another really great organization.
Kathy, I wanted to thank you so much for an excellent webinar today. I don't know about all of the participants, but it really brought the 6 to 12 and 9 to 3 to light for me. So thank you for a really great demonstration also of the clock method and for bringing all this great information available to us today. What I thought what we would do next is, we've just heard a lot about the push tool, but I'd like to get a sense of where the audience is in terms of using the tool today in your facility. So I'd like to ask what you currently do, if anything, with the push tool today. Not what your intentions might be, but what you currently might be doing with the push tool today. So we're going to do another one of those quick polls. So give us a second here, and we're going to push out another poll. And everyone, if you could take a moment to vote with us today and share with us how today your organization uses the push tool. We'll gather all these responses over, say, the next 30 seconds or so, and then I'll go ahead and show you how everyone on the call today voted to see how facilities today are using the push tool. And then perhaps as you're indicating how you use the tool, you might also get some ideas about how you might use the tool going forward to help advance wound care within your facility. So we're still seeing a few people voting. It looks like the original intent of the tool, the most base element form, was to track wound healing, and it looks like that's how most of you use the tool today. So I'm going to go ahead and close this poll right now. I think everyone has voted, and let's share with you guys what everyone had to say. So it seems like we have a great deal of facilities out there that are using the tool exactly how it was intended to help promote wound healing, but perhaps you also see there's some other ideas here on how this very valuable tool can assist you as you're providing wound care in your facilities. So as we're wrapping up here today, I wanted to take this opportunity to open the floor up to questions, and also to remind everybody that this is the contact information for Kathy O'Toole, our presenter today. And if we don't get to your question today, we're going to try to, that we also invite you to reach out to Kathy outside of this webinar. She has a lot of great advice for facilities. So at this point, what I'd like to do is take a look at our questions and then share it back with the audience. Here's a great question that I'd like to ask of Kath. Kathy, we've talked about the push tool today as being used with pressure ulcers, but can it be used for other types of wounds?
Hi, Deb. Hi, audience. That's a great question. Yes, it can be used. Although it was created specifically with pressure ulcers in mind, remember it was created to show healing trends or healing over time. And as a validated tool, it helps to identify key elements in the healing, which are wound contraction, exudate amount, and the tissue type. So yes, it can be used with wounds other than pressure ulcers.
Thanks, Kathy. See another question. It seems that there's still some confusion about depth. So we know that we do length, width, and depth for measuring wounds, but how come it's not part of the push tool?
Again, another great question. If you utilize the wound length, width, and depth, you'll get the wound volume, which is very important for our comprehensive assessment, although, again, keep in mind that the push tool is meant to be something that's very quick, very easy, and is showing wound healing. And again, as a validated tool, we know that utilizing just the length and the width are indicative of wound healing because, again, pressure ulcers are healing by contraction. We wouldn't want to have a wound that remained at 4 centimeters by 3 centimeters and healed over with epithelialization, because then we would have tissue that would be very easily disturbed when a person, regains their natural activity. So yeah, the tool, again, created to be very simple, very easy to show the wound healing.
Thank you, Kathy. So I saw another question came in, and this question has to do with what if a wound has both granulation tissue and slough? How would you go ahead in scoring this wound on the push tool?
That's another great question. If you had a wound that had both granulation and slough, we know the wound is moving towards healing because of the granulation tissue, but again, keep in mind that slough is non-viable tissue, and so what we would want to do is we would want to put on the push tool the most abnormal tissue, because that is still what the body has to deal with. So in that purpose, in that wound, for our purposes on the push tool, we would give that a 3. Which is what the slough would be. So yes, you would go with slough.
So Kathy, some questions are coming in about how we can actually utilize the push tool in facilities, particularly in facilities where the push tool is not actively used today. So one question has come in about how do we get compliance and drive adoption of the tool across the facility? And wondering if you can speak to any best practices in helping to bring a bunch of clinicians across different functional areas on board and using this tool.
Again, these are great questions. I really like this. It's really important to understand that wound care is very much on the radar, and that part of the work of the NPUAP has been done because they've brought it to the forefront, as well as there's a lot of increasing research to show the science behind wound healing. And so knowing that they wanted to have a tool that was very, very easy to utilize is the first thing. So it is an easy tool. It's also important to understand that electronic or automated tools are progressing in the healthcare arena and are in increasing demand. Also, with the current economic environment in healthcare, which is not likely to get better anytime soon, it's critically important to make good use of staff time, as we know that we're all being asked to make dollars go further. So I would say it's really imperative to look at the utilization of newer devices that help improve or provide a comprehensive picture of your total wound patient, the trends in your facility, treatment trends, etc. And so I would really suggest to anybody to look at some of those electronic devices, but also to just realize that the tool was made to be very simple and to be quick and to be only part of an assessment that you're already doing. I think lastly I would say, because I am, WoundRounds is hosting us, that WoundRounds has a wonderful tool that utilizes the push tool, and they provide an excellent electronic device for a very comprehensive assessment of wounds.
Thanks, Kathy. We see some questions coming in regarding the frequency by which one would do an assessment or whereby charting a push tool. So one question has come in from acute care, where they're reminding us that their average length of stay for a patient is between 3 to 5 days, and wondering just how often you would recommend use of the push tool under those types of settings.
The push tool in the acute care setting, with the length of stay being so short, I would say you might want to do it daily. You can see wounds change daily, but you're really more likely to see them change over the course of a week. And again, you can see a wound change from a small amount of Exudate to a more moderate amount of Exudate within a day. But really, I would say for the acute care, you may want to use it for things other than pressure ulcers, but in terms of length of stay related to seeing these pressure ulcers heal, I would say you would want to do it every couple days, keeping in mind that the average length of stay is 5 days. Certainly, if they're there longer, well worth it to utilize the push tool for patients that are going to have longer stays. And keep in mind that we know that patients that have pressure ulcers have extended stays. And again, the average being 5, but more likely someone with a pressure ulcer will be hospitalized for anywhere from 13 to 15 days, sometimes longer if they've got other comorbidities.
Kathy, thank you. So we have had some questions along the lines of frequency of using this tool. So now it's not a great question that's come in regarding the stage of pressure ulcers. And this question comes in regards to, would you recommend this tool for severe pressure ulcers, say stage 3 or 4?
This would be an excellent tool for stage 3 or 4. And although, again, our comprehensive assessment will go into much more detail about the wound, the color of the exudate, things like that, the push tool, remember, we're identifying 3 critical components of healing, which is the length and the width. We do want to see it getting smaller. The exudate amount, we certainly do not want to see the wound exudate increasing, because that can mean that you have more bioburden in the wound. And obviously the tissue type for stage 3 or 4, you're more likely to have, I don't know if more likely is the appropriate word, but certainly with a 3 or 4, if you have necrotic tissue, you need to clean out that wound bed, and so your tissue type would go from a 3 or 4 down to hopefully a 2, you know, I'm sorry, 3 down to a 2, down to a 1, and then to closure. So yes, absolutely can be used for those wounds. Critical in those wounds, I would say.
So we have time for one last question, and I think we've been talking so much about the use of the tool and how great it is. We have one question asking, we don't presently use the push tool, she writes, in her facility. Is this perceived as a bad thing? Kathy, I'm wondering if you could comment on that.
Good or bad, that's kind of a judgment call, but I would say to utilize the tool, it's available on the NPUAP website, I would say that you would find that utilizing the tool is a really great way to get a really nice quick look at people's wound to see if they're healing. And so I would suggest, if you're not using it in your facility, absolutely to begin to use it, whether you're using the paper form or whether you actually have the ability to entertain some of the electronic devices that are available out in the healthcare arena. So absolutely, I would say it's well worth it to investigate it. There are directions for use on the NPUAP website, and as you can see as we went through, I hope that I was able to really show you how quick and easy the tool can be, and certainly that was the goal of it. And also keep in mind that the 3 elements that are evaluated within the tool are those elements that are indicative of wound healing. So again, I would encourage you to begin to use the tool.
Kathy, thank you today. As we're wrapping up today's webinar, I wanted to again give you an opportunity to take down Kathy's contact information, if you will. And I wanted to take this opportunity also to give a thanks to our sponsor, WoundRounds. WoundRounds is the electronic and point-of-care wound management and prevention solution. It helps nurses to essentially do more with less. In the case of the push tool, it is an automatic calculation of the push tool. And so imagine getting all this great information with every assessment you do with the push of a button. So big thanks to WoundRounds today for sponsoring this webinar and making Kathy's valuable information available to us. So I wanted to remind you what's next is you'll be receiving an email from WoundRounds with a link to this archived webinar. It will also include a link towards a copy of the handouts. If you didn't get the handouts in advance, you can another shot at getting the handouts. And also keep abreast of future emails that will come from WoundRounds. This is the 7th in a webinar series brought to the community from WoundRounds, and we're hopeful to see more topics coming again in the future. So with that said, my name is Deborah Kurtz, and I wanted to one more time thank Kathy O'Toole for a great presentation today, and a thanks to WoundRounds for making this all possible. We'll look forward to catching you at the next webinar. Thanks again.